This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Cancer Medicine, set to be published in early 2026. It's titled Clinical Outcomes and Prognostic Factors of Stereotactic Radiotherapy for Spinal Metastases with Epidural Spinal Cord Compression Grades 1 to 2.
This is a topic that hits right at the heart of our daily decision-making in the multidisciplinary spine oncology clinic. Historically, when we see epidural spinal cord compression, or ESCC, our minds often jump straight to separation surgery, followed by SBRT. We've been taught that we need that surgical margin to protect the cord before we can deliver those high, ablative doses of radiation.
Exactly, Dr. Aris. The classic paradigm has been that for patients with significant compression, surgery is the prerequisite. But this study, led by Hong-Quing Zhuang and colleagues, asks a very provocative question. Can we achieve the same local control using only SBRT in patients with ESCC grades 1 and 2, provided their spines are stable?
It's a bold move. They specifically looked at patients who did not undergo surgery. For our listeners who might need a quick refresher, let's define those ESCC grades as used in this prospective study.
Right. The authors used the standard T2-weighted MRI-based scale. Grade 1 is where the tumor has epidural extension and is abutting the spinal cord but not displacing it. Grade 2 is more advanced. The tumor actually displaces or compresses the spinal cord, but it hasn't completely obliterated the cerebrospinal fluid space or surrounded the cord circumferentially.
So we're talking about patients who have real compression, but haven't reached that grade 3 tight compression where the CSF is totally gone. Now, Ilara, walk us through the patient cohort. Who exactly was included in this trial?
They enrolled 65 patients with a total of 71 metastatic lesions between September 2018 and January 2024. The primary cancers were quite varied, though renal cell carcinoma was the most common at 69%, followed by lung cancer at about 15.5%, and some thyroid and breast cases. Interestingly, the median age was 60.
Renal cell is a key one there because we typically consider it radioresistant to conventional external beam radiation, which makes SBRT even more critical for those patients. But before they could even consider SBRT alone, they had to ensure the spines were stable, right?
Correct. They used the SINS, the Spine Instability Neoplastic Score. Patients with vertebral instability requiring surgery were excluded. Most of their patients fell into the 0 to 6 range, which is stable, or the 7 to 12 range, which is potentially unstable but didn't necessarily require fixation in this context. They also excluded patients with severe pain who couldn't lie flat for the treatment, or those with such widespread disease that SBRT wouldn't be appropriate.
Let's get into the how. For a neurosurgeon, the dosimetry and the fractionation are where the magic and the risk happens. What was the SBRT protocol?
They used the CyberKnife platform with real-time spine tracking. This is high-precision stuff. The gross tumor volume, or GTV, included the epidural and paraspinal components. They added a 3 mm margin to create the planning target volume, or PTV. Crucially, they retracted the PTV where it overlapped with the spinal cord to stay within safety limits.
And the dosing? I noticed they used 3 different regimens based on the lesion volume and the degree of compression.
Yes, they were quite specific. For small lesions involving the appendages or less than 2/3 of the vertebral body, they gave a single fraction of 24 gray. If the entire vertebral body or one side of the appendages was involved, they moved to 30 gray and 3 fractions. And for the most extensive involvement, the vertebral body plus bilateral appendages, they went with 40 gray and 5 fractions.
So they are pushing the dose while fractionating to protect the cord. In fact, they mentioned that the final decision on fractionation was always driven by the spinal cord's tolerance limit. Now, the million-dollar question, did it work? What was the local progression-free survival, or LPSS?
The results were actually outstanding. Out of the 71 lesions, only 3 showed local progression during the follow-up period.
Only 3? That's impressive local control for tumors that are already touching or displacing the cord. Did the degree of compression, grade 1 versus grade 2, make a difference in how well the radiation worked?
That was one of the most significant findings. They did a comparative analysis and found no statistically significant difference in LPSS between grades 1 and 2. The p-value was 0.769. Even in the multivariate analysis, the ESCC grade wasn't a significant factor for local treatment efficacy.
That's a huge point for our residents to grasp. We often worry that grade 2 compression is too much for SBRT alone because of the lack of a buffer zone between the tumor and the cord. But this data suggests that with modern tracking and dosimetry, grade 2 behaves much like grade 1 in terms of local control.
Exactly. The paper suggests SBRT could be an effective alternative to the traditional surgery plus radiation route for this specific subset of patients.
But we have to talk about safety. When we deliver 24 to 40 gray right next to the cord, especially when it's already being displaced in grade 2 cases, I'm looking for radiation-induced myelopathy. What did the toxicity data show?
This was perhaps the most reassuring part of the study. There were 0 cases of spinal cord injury. None.
That's remarkable. No radiation myelopathy in a cohort where the cord is already compromised.
Right. They did see some other toxicities, though. Esophagitis or oral mucositis occurred in about 33% of cases, though only 1 was grade 3. Nausea was present in nearly 20%, and they had a few cases of vomiting and acute pain flares. They did report 1 case of grade 2 late neurological damage, which was about 1.4% of the cohort, but again, no actual cord injuries.
It speaks to the precision of the cyberknife and the Monte Carlo algorithm they used for dose calculation. They were using 70 to 80% isodose lines and ensuring the PTV coverage was over 95%. It shows that if you are rigorous with your constraints, you can treat these safely.
The authors also mentioned that for patients who did have grade 2 compression, the local control was just as robust as grade 1. This really challenges the idea that we must create a surgical gap for every grade 2 patient.
It does. However, as a surgeon, I have to play devil's advocate. We have to remember their exclusion criteria. No vertebral instability. If that tumor has eaten through the pedicles and the posterior elements to the point where the spine is mechanically failing, SBRT isn't going to fix that. Those patients still need us in the OR.
Absolutely. The study is very clear that this applies to patients without vertebral instability. They used the SIN score to filter those patients out. If the spine isn't stable, the SBRT alone approach isn't the conversation we're having.
Let's dive deeper into the prognostic factors. Did they find anything that did predict failure? If ESCC grade didn't, what did?
Interestingly, when they looked at the multivariate analysis, ESCC grading just didn't move the needle on LPSS. The primary goal of the study was to provide a curative dose for these metastases. They aimed to offer insights for clinical management by showing that if you can deliver these doses, 24, 30, or 40 gray, the biology of the tumor seems to respond regardless of that initial grade 1 or 2 compression.
It's a shift toward looking at the separation in separation surgery as a biological or dosimetry concept rather than purely a physical surgical one. If you can get the steep enough dose gradient, the separation is happening in the radiation plan itself.
And for the patients, skipping a major spinal surgery is a huge benefit. Less recovery time, fewer surgical complications, and they can stay on their systemic therapies, like the ones needed for their renal or lung cancer with less interruption.
Definitely. For our residents listening, the takeaway here isn't stop operating. The takeaway is select better. If you have a stable spine, SINs 0 to 6, and ESCC grade 1 or 2, you should be having a very serious conversation with your radiation oncologist about definitive SBRT before picking up the scalpel.
The authors concluded that for these grade 1 to 2 patients with no instability, SBRT alone has outstanding local control and minimal toxicity. It really validates what many centers have been starting to do, but provides that solid clinical evidence that was previously lacking.
It's a great study. It's prospective, it uses clear grading scales, and the outcomes are very clean. It'll be interesting to see if these results hold up in larger multi-center trials, but for now, it's a strong piece of evidence for our specialty.
It definitely gives us more confidence in the cyberknife's ability to handle these abutting and displacing lesions safely.
Well, that's all the time we have for today. Ilara, thank you for breaking down the data.
My pleasure, Dr. Aris.
To our listeners, residents, and attendings alike, keep looking at those T2 images closely. The difference between a grade 2 and a grade 3 could be the difference between a trip to the OR and a trip to the radiotherapy suite.
Thanks for tuning in to the Neurosurgery Hub podcast. We'll see you next time.
Stay sharp.